Well, great. Thank you very much, Carol. Can you hear me okay?
You sound great.
Well, great. Thanks for that introduction. Always, you're too kind in what you say about me. I find 2 or 3 things every day about meaningful use that I don't know. And so while we do find out things every day, there are new things that we don't know every day. So it's kind of an ongoing process. Digging through stage 1, and of course we've got stage 2 and 3. In this session, we're going to talk about 2 of the core and 3 of the menu objectives that have to do with eligible providers and clinical practices exchanging information really with patient communication. This is really an interesting area for me, and whereas traditionally there's been a certain amount of communication between practices and patients, under stage 1 of meaningful use, a lot more functionality is being required. And so there's going to be certainly some new workflows that we are not used to in the ambulatory environment. So looking forward to talking about that here over the next few minutes, as well as just maybe not some direct facts, but just some of my musings about how I think some of the workflows might best be associated. I want to cover a couple of standard things we always like to talk about. The course 25 core objectives for eligible providers for stage 1 meaningful use, broken down to 5 different groupings. In this session, it's really around engaging patients and families in their health care, communication, kind of a bilateral communication going back and forth. And so that's going to be the primary areas we'll talk about in this session. I mentioned 25 meaningful use objectives. 15 are in the core set that technically have to be met. And then the 10 menu set objectives, of which 5 may be deferred, have to do at least the 5 that are left, either being immunizations or public health surveillance. So it gives us 25 stage 1 objectives. 5 could be deferred. That sounds like leaves us 20, but as we've discussed, for those specialists or other providers who have the ability to exclude some of these objectives because they're outside of their scope, then quite possibly much fewer than 10 excuse me, I misspoke there. Yeah, much fewer than 20, and possibly 10 or 12 meaningful use objectives for some specialists is all that they'll really be required to demonstrate for stage 1 to get the full incentives. Each one of the meaningful use objectives examined from 3 different directions. One is the objective itself. Second is the measure, how the objective is going to be measured, and then any possible exclusions. The measures themselves break down into 2 categories. There's either affirmative or negative, whether the objective has been done or not. An example of that is drug-to-drug interactions. It's either turned on or not turned on. Clinical decision support. It's either on or it's off. No percentages there at all. But the majority of the meaningful use objectives are percentage-based. An example would be, and we'll examine the one tonight for a provider having to, based on a patient's electronic health record, give patient-specific and appropriate educational resources to that patient. At least 10% of those unique patients must be given this information. So we have a real percentage there, so we have a denominator and a numerator and a subsequent percentage. In stage 2 and stage 3, it is expected that these percentages will increase. Some exclusions. Some of the objectives have exclusions, but not all. The ones that are not applicable to every provider's clinical practice frequently have exclusions. or if there are no eligible providers or actions that are possible for the measured denominator. Also, even when there is objective like clinical quality measures that must be reported. If it's if it's outside the scope of a provider's population and they have no patients to report a quality measure on, it's okay to report 0, so that's fine. And those exclusions do not count against the 5 deferred menu set objectives. And so I'm going to just take a little detailed look at 2 of the core and 3 of the menu objectives that are really focused on this information and data exchange with patients. I always like to define a few terms here. The concept of a unique patient is becoming more and more significant as we look into the meaningful use objectives. If a patient is seen by a eligible provider, more than once during a particular reporting period, typically that first year, as we know under the meaningful use incentives, that initial year could be as short as 90 consecutive business days, could be longer, could be up to the entire year, number of factors there. But if a patient has numerous encounters for a significant number of these objectives, that patient is just counted one time. So really looking at unique patients during that encounter basis. And the measures that do rely on that term unique patient relate to what is contained in the patient's medical record. One example here of a unique patient and a subsequent percentage meaningful use objective would be the requirement for information to be in the patient's list, patient's problem list. So the denominator would be the number of unique patients during the reportable period. The numerator would be those patients, if there is something, those unique patients, if there has been something in that problem list, whether it's an actual codified diagnosis or some structured indication that the patient has no diagnosis or no problem. And so that does not have to be updated, that information with every encounter. All that's really going to be calculated is number of unique patients in that reportable period, and of those unique patients, what number of them actually had a presence of something structured in the problem list. So that's why the concept of unique patient as opposed to a encounter-by-encounter basis is very important. Patient-specific education resources. This is really fascinating here because the CMS requirement says resources identified through logic built into the certified EHR technology which evaluates information about the patient and suggests really appropriate educational resources. Now, this would lead us to think that if you gave a patient a particular diagnosis, let's say of diabetes, that the EHR itself would perhaps suggest a particular document or information source that can be printed out or the patient can be directed to. Or also it would need to be based on not only the problem list, but medication or particular lab test results. And so the educational resources must be specific for and pertinent and relevant to an individual patient. Definition of an office visit, really 2 types of office visits that CMS involves here in their definitions. One is defines a visit as a separate billable encounter that result from evaluation management services provided to the patient and include concurrent care or transfer of care visits, consultant visits, or prolonged physician service without direct face-to-face patient contact. Telehealth, we don't see too much of that, but we may see more of that going forward. And the consultant visit occurs when the provider is asked to render expert opinion of service for a specific condition or problem by a referring provider. Diagnostic test results, CMS, for the purposes of meaningful use, defines that as data needed to diagnose and treat diseases. certainly way beyond the scope of pure chemistry results they're looking for here. Blood tests, micro, urinalysis, pathology, radiology, cardiac imaging, nuclear medicine tests, pulmonary function tests, and other related type diagnostic procedures. The concept of business days is important here for a number of reasons. And we'll see that there's an actual time period when some of these communications have to take place, whether they've been requested by a patient or not for information. And so the idea that when they talk about days, they're really talking about business days, defined as Monday through Friday, excluding the federal and state holidays. Get the details of those in just a few minutes. Clinical summary. We'll run across a meaningful use objective coming up in which there is a requirement to provide patients with a clinical summary. And the definition, the working definition here is that this is a visit-focused summary. This is the type of documentation that will be generated based on a particular encounter. And really has all the updated medication lists, vitals, the reasons for the visit, any procedures that were done, instructions or possible referrals that came out of that particular encounter. So there's going to be a requirement in one of the objectives for clinical summaries, as well as for a copy of patient information. The first core objective we'll look at in detail is this electronic copy of health information. In the paper world, when I worked in a medical practice, I remember about the worst thing that could happen was somebody would show up at the front desk and say they wanted a copy of their chart, and they'd be glad to wait. And so sometimes it would take hours to locate a chart, print a chart, find out what had to be printed, what we could print, what we could copy. Very, very difficult to actually come up with what this health copy of the record the patient wanted. But this is a core objective that there is a requirement to provide a patient with an electronic copy of their health information. As defined, this must include the diagnostic test results, their problem list, medication list, and medication allergy list upon request. Kind of interesting for stage one that allergies related to food, environmental, or other exposures is not specifically named, just medication allergies. The measure for this objective is that more than 50% of all patients who request an electronic copy of their health information have to be provided within 3 business days. So if a practice or a physician or some other provider, eligible provider, receives a request, this is request-based, from a patient that they want an electronic copy of their health information, it has to be provided within 3 business days. The only exclusion is any eligible providers that have no request from patients or their third-party agents during that reporting period for a copy of the patient health information. The threshold percentage is 50%, and the denominator is, since this is request-based, not based on unique patients, it would be the number of patients who request an electronic copy of their electronic health information 4 business days prior to the end of the EHR reporting period. And of course, they say that since we have 3 days to provide this information, and the cutoff date of the numerator, denominator, and percentage is the end of the reporting period, we would really only count requests up to the 4th day prior to the end of the EHR reporting period. The numerator is the number of those patients who receive electronic copy of their health information within 3 business days. Now, one of the fascinating parts to me, and this is really going to be workflow related, is how are we going to keep track of this? That denominator, if patients call in and they request a copy of their electronic health information, or they show up, or they're in the office and ask their provider, that's got to be logged in some way. Some EHRs have very elegant functionality to track this electronically. Some EHRs don't, but there's got to be some way to keep tally, whether it's on paper or electronic, of how many requests might generate a reportable period. And then also there must be a tally, electronic, paper, or some hybrid system of the number of these patients who were given their information within 3 days. Some possibly challenging workflow things here, and certainly something to be thought about quite a bit to make sure that double and triple work is not being done. Exclusion is, of course, any eligible provider who has no requests from a patient or an approved third-party agent for a copy of the information. And this can be certainly excluded. Some additional information is that the requirement to meet this threshold of 50% within 3 days to provide this information if it's requested is that we can limit this objective to those patients whose records are maintained in a certified EHR. So if there is another location you might be seeing patients at, and they're on a paper-based system, this meaningful use objective, we're not required to track it over there, certainly for stage 1. HIPAA certainly becomes involved here. There's certainly HIPAA requirements about access of individuals to protected health information, and certain requirements for providing patient copies of their health information. So there are a number of issues around this objective. The first look at it, it seems simple enough, but this one, more than quite a few others, is going to require some significant thinking through of the proper workflow, in light of the HIPAA requirements around the release of this type of information. Eligible provider may withhold information from the electronic copy of patient's health information, and that's based on some of the HIPAA privacy rules and standards. And the requirement also that the form and format should be human readable. Media can be any electronic form, such as patient portal, PHR, compact disc, USB, thumb drive, and really the requirement is to make reasonable accommodations for the patient preference, as outlined in the rules and regulations. The easiest way that I think I've seen some practices approaching this issue is that they're going to have a very robust, mature PHR or patient portal of some type where they can release information to a patient's PHR and almost universally push everything that they generate on a patient directly into that patient portal. And then when the patient requests, if the patient should request something, they can be directed straight to that patient portal. That's just one possible workflow around this issue. But to me, the most possibly significant part of it is there is that requirement that we track those requests, and there's a time limitation on that at least 50% of those requests within 3 business days are met for stage 1. I would imagine that for stage 2, this will get higher. There can be charging fees for this. They are hard to say what is reasonable, but HIPAA-covered entities can charge an individual a reasonable cost-based fee for a copy of their health information. if the patient wants to receive, has stated in their communication preferences that they want to receive this type of information by mail, then it should be in the mail by at least the third business day. They don't have to necessarily get it by the third business day as long as it's mailed by the third party. By the third day. And third party request, certain specific third party requests for information will be included in the denominator. Authorized representatives, family members, parents, those entities that are consistent with federal and state law may substitute for a patient-signed disclosure of information and count in the numerator. So in most cases, but not all cases, these third-party requests would be included in the numerator or the denominator. The next objective, which is a menu set objective, is very simple, but is very, very similar to what we just looked at, which was a copy of the health record. Here we're looking at really a clinical summary. Clinical summary being based on an actual and focused on a particular encounter. The objective here is to provide clinical summaries for patients for each office visit. That means every time there is a clinical encounter, an office visit, a clinical summary is generated and provided to the patient. Probably not a lot of that going on now in most offices. The measure is that clinical summaries should be provided to patients for more than 50% of all office visits within 3 business days. I can remember when a few years ago when I worked in a large pulmonary practice where there was quite a bit of documentation that was being done by transcription, and we would not get the transcription back for a week or longer sometimes, and not even signed for a longer period. Now, this affects that type of workflow quite a bit. But if we're using a certified EHR, these clinical summaries should be really ready by the end of the encounter. And at the end of that encounter, when that encounter ends, within 3 business days, these clinical summaries should be available to at least 50% of all office visits that have occurred. The only exclusions are any eligible provider who's had no office visits during the EHR reporting period. And that makes sense because some specialists really are not involved in direct patient care and office visits. Attestation requirements, denominator, back to that phrase, number of unique patients seen by the eligible provider for an office visit during the EHR reporting period. And the numerator is the number of those who were provided a clinical summary of their visit within 3 business days. There are a number of different workflow thoughts that I've had about this. Since this is not request-based, this is not the patients or their healthcare power of attorney individuals requesting information. The requirement here is not request-based. It is when a clinical encounter takes place within 3 days, that summary's got to be available. And so I've seen many EHRs that are developing, as I mentioned with health record, robust patient portals or other ways to just go ahead and push that information out there. So every time there's an encounter, that encounter summary is pushed out to that patient portal. That way they're not having to keep track of anything. So their numerator and denominator is, and percentage, subsequent percentage is going to be 100%. One way to look at it, do it that way. Additional information, the provider is permitted but not required to limit the measure of this objective to those patients whose records are maintained using certified EHR. Again, if there's you see in some subset less than 50% of your patients at a clinic where it's paper-based, we don't have to meet the meaningful use objective for this. And the clinical summary is limited information that's actually contained within the certified EHR. So when the summary is generated, it can come straight out of the certified EHR. We don't have to go digging for other information to include into it. Clinical summary can be provided through the personal health record, patient portal on the website, secure email, or some type of electronic media, such as CD or USB thumb drive or a printed copy. If the provider chooses electronic media, they'd be required also to provide the patient a paper copy upon request. One way that I've seen quite a few providers doing the workflow around this is every encounter that generates a clinical summary, as I said, is automatically pushed to a patient portal. And sometimes these patient portals are outside the EHR. They can be pushed to, I've seen instances where they're being pushed to Microsoft Health Vault. And then the patient could have an account at Microsoft Health Vault, log in, and see their clinical summary that has appeared there within a certain number of days after an encounter. So probably the many different ways that we see the workflow around this objective. If an eligible provider believes that substantial harm may arise from disclosure of particular information, they may choose to withhold that particular information from the clinical summary. To me, this means that if some lab tests have come back, some cytology or some pathology or perhaps some other type of lab tests have come back, and the provider really wants to discuss that face-to-face or in some other venue that's more personal than just dropping it on somebody's PHR for them to read. It's okay to hold back that particular patient information and give it to the patient in some other manner. Patients should not be charged a fee to provide this information. And interestingly, and this last guidance here from CMS is really fascinating because I was asked this question several times last month. When a patient visit lasts several days and the patient is seen by multiple eligible providers, what is the denominator? Who gets credit for that clinical summary? And CMS says that a visit goes over numerous days and or numerous providers. And when I say a visit, certainly there are situations where a particular problem is acute with a patient and they may be in and out of the office 2 or 3 times over 2 or 3 days or more. A single clinical summary at the end of the visit series, I guess really it should be said here, can be used to meet the meaningful use objective for providing clinical summaries for patients after each office visit. So if they're in 3 days in a row for one problem, we don't have to generate 3 clinical summaries. One will do. The next meaningful use objective from the menu set is patient reminders. And again, going back to workflow from paper-based systems, patients would be called that maybe to remind them they had an appointment, or maybe that they were due to come in for a particular lab test or some type of other recheck based on health maintenance or some type of wellness activity. This is being taken to the next level with electronic EHRs and stage 1 meaningful use. The objective is to send reminders to patients based on their patient preference for preventative and follow-up care. And when it's spoken of here per patient preference, that's really their communication preference. Do they want these reminders to come to them by telephone or by email or a letter in the mail? It's really supposed to make, eligible provider is supposed to make an effort to communicate with the patient in ways that is really determined by the patient. The measure for these reminders is that it's age-based, and so that more than 20% of all patients 65 years or older or 5 years or younger were sent an appropriate reminder during the EHR reporting period. But what does that mean? What that means is that they want to make sure that providers are communicating with their patients and reminding them of things. For those practices who are based on episodic care or when we'll see the patient when the patient calls us, this is an attempt to kind of turn that around a little bit. And so for those patients, again, that population of over 65 or under 5, at least 1 out of 5 of these were sent some type of reminder during the EHR reporting period. Again, the initial year, that could be a 90-day period. Subsequent years, it could be 365 days. The exclusion would be a eligible provider, no patient 65 years old or older, or 5 years old or younger, whose records are being maintained with a certified EHR technology. That's the denominator. And the numerator is those patients who are actually sent some type of appropriate reminder. Again, these reminders could be you have a visit coming up, or you are overdue for an immunization, or it's time to come back for a recheck of some type of glaucoma testing. A pretty wide variety. It looks like that the impetus here is really to start having practices reach out and start owning the communication towards the patient with reminders for wellness and disease management. Some further clarification, always CMS says you're permitted but not required to limit this objective to those patients whose records are maintained using certified EHR technology. We discussed that we want to try and meet the aspect of per patient preference with how they want to, the patient wants to be communicated with. The eligible provider also has the discretion to determine the frequency, means of transmission, and the form of the reminder. And the only real limitations here are the HIPAA privacy rule and any other applicable federal, state, or local regulations. The next meaning for use objective is from the menu set, patient electronic access. This is a requirement to provide patients, the objective, with timely electronic access to their health information. And that is defined by the final rule for meaning for use as at least lab results, problem list, medication list, and medication allergies list within 4 business days of the information being available to the eligible provider. The measure is that at least 10% of all unique patients, so that phrase again, unique patients seen by the eligible provider are provided timely, that's defined as within 4 business days, electronic access to their health information, and also discussed earlier, subject to the provider's discretion to withhold certain information because it could cause some type of harm, or the timing of that delivery of certain types of information. The exclusion is any provider that neither orders nor creates lab tests or information that would be contained in the problem list, medication list, medication allergy list during the EHR reporting period. To me, this is very similar as to the workflow around it that we've seen with some of the other objectives. I think this is going to be met quite possibly with a patient portal, and there are numerous ways to create a patient portal. Again, some certified electronic health records I've seen make it very easy, since this information is not based on a request from the patient. This information has got to be pushed out. Really for all patients. We don't know who's going to come to it or not, but we're going to put it out there for them. An easy way may just have a patient portal, or pushing this certified technology, pushing out to Microsoft Health Vault. I have seen some certified EHRs that allow the patients to actually become users in the EHR. And they're given a user ID and password, the login over the internet, but the only thing they can see is their own record in the read-only status. So a lot of different ways this is going to be met. The denominator are those unique patients seen by that particular eligible provider during the EHR reporting period. Numerator is number of those patients who have timely, within 4 days of information being updated, electronic access to their health information online. And so this only has to be for 10% of those patients. And so, again, one way, depending on the workflow, could just be the certified EHR that anytime a patient's record is updated, based on a problem list, medication list, or medication allergy list, that it's reflected within 4 days in the patient portal, or in some other way that the patient could log in and actually see it. In that case, the resulting percentage, if it's set up in such an automatic fashion, would be 100%, because it would always be available there to every patient. We're not really tracking which patients come and actually look at it, just as made available to that percentage of the unique patients. A little more additional information on this objective, the online access. When this first came out, many individuals thought, well, this could be just email. You could just email some health information to a patient, but that's not true. It's very required that this is online electronic access, either through a patient portal or personal health record will satisfy this measure. Eligible provider may decide that electronic access to the portal or a PHR is not the best form to communicate results. And so some good flexibility here, where CMS has said we will defer to the eligible provider's judgment as to whether to hold information back in anticipation of an actual encounter between the provider and the patient. Talk about delivering bad news. You don't want to deliver bad news to a patient portal or just drop it into a PHR, and that's really what they're talking about there. And the information that must be provided electronically is limited to that information that is in that certified EHR or is easily accessible by that certified EHR. HIPAA. We have the shadow of HIPAA through all this. And certainly when we're talking about disclosure and release of electronic health information or any health information, we're going to be talking over and over about HIPAA. And so the eligible provider may withhold information from the electronic copy of the patient's health information in accordance with some of the rules and regulation of the HIPAA privacy rule. The objective and measure focus on the availability of access and the timeliness of the data, not utilization. And so the only requirement is the eligible provider make this information available for the patients to come to through electronic online access. The providers are not responsible for ensuring that at least 10% of the patients actually come and do it. Only that 10% of all unique patients seen by eligible provider could access the information if they so desired. Good rule there. Patient-specific education resources. It's a menu objective, kind of a fascinating one here. This is a good example in which there is still a little bit of fuzziness between what is required from the certified EHR technology standards and the CMS meaningful use objectives. The objective is that the eligible provider use the certified EHR technology to identify specific, patient-specific education resources and provide those resources to the patient if appropriate. The measure is that more than 10% of all unique patients seen by the eligible provider are provided patient-specific education resources. So if my reportable period is a year and I've seen 4,000 patients this year, 4,000 unique patients, then over 10%, over 400 of those, I have to provide them patient-specific education resources. No exclusions here, but there are some few complicating factors. Denominator, again, just all those unique patients eligible provider saw during that EHR reporting period. Numerator being the number of those patients who were provided those patient-specific education resources. That's based on problem list, medications, and lab test results. So at least 10% of those patients should be given. The certified EHR technology is certified, and I've been through numerous of these certification tests where the tester has the EHR demonstrate how can you identify what patient-specific records, educational resources would you provide to the patient, and how would you do that? And so during the test, could look at a patient's record in the EHR, see they have diabetes, see they're on Lipitor, see they had an LDL of 125, and find some, do a search either for local documents that are kept in the EHR or link to Medline or some other online repository of this type of information. Locate the particular brochures or articles, print them out, and give them to the patient. And that's part of the second item here. The resource materials designed to be stored within or generated by the certified EHR. They could be, but they don't have to be. They can be local documents. They can be documents that are on the internet, or they could be both. The provider should utilize the certified EHR technology in a manner where the technology suggests patient-specific educational resources based on the information stored in the certified EHR. And so there is, as I mentioned, there's still, to me, a little bit of confusion here. During the actual certification test, all that's required is that the tester can see a patient's problem list, see a patient has diabetes, and then there just has to be a demonstration that the operator of the EHR could go locate either locally or through some type of link within the application to some online resource, do a search for diabetes and print it out. And that's been fine. But here there is some language that says the technology suggests patient-specific education resources. So I think there's going to have to be a little harmonization between what's required on the certified side and the meaningful use side. Hopefully that'll get worked out in the next month or so, or next few weeks. The provider can make the final decision of whether the education resource is useful and relevant to a specific patient. I always like to talk about different resources. The first one is the incentive roadmap. That's the manual that I authored on the meaningful use for eligible providers for stage 1, kind of a step-by-step approach, including certainly the topics of quality measures and meaningful use for specialists. The virtual extension center at www.hightechanswers.net. Anybody who's listening to this or participating in this evening, I believe is probably always a member there. And any questions that come up, if we don't answer them tonight, you can direct them there. And we've got some pretty good resources and connections. And if we can't answer a question, we can usually get some type of response back from CMS within usually 2 days at the most. So going to be a lot of questions through stages 1, 2, and 3. And then, of course, the CMS website for the Medicare and Medicaid EHR incentive program, lots of information there. So with that being said, Carol, I'll be glad to turn it back over to you, and we can maybe talk about a few questions and answers.
Yeah, we got a few questions that came in, and actually that was
sure.
That was pretty in-depth, but pretty informative, and certainly probably more straightforward than some of our earlier objections that we covered last week. The first question is, and this was very early in the presentation, could this educational information be generated by the physician, or must it be from an outside source?
Great question. It is totally up to the eligible providers. If they have brochures in their office that they want to hand to a patient, they can do that. If they again, from within their application of the URL and print it out, that's fine. If they have their own specific documents that they can print out, that's fine also. So these documents and this information itself does not have to reside within the EHR.
Yeah, you talked about the right at the start of the presentation, right?
Yeah, and one other thing I want to mention this is, again, this is part of workflow. How are we going to keep track of who we give educational resources to? Since it's over 10%, there's got to be some way, either in the EHR or a manual log or something, to keep track of how many unique patients we give this stuff to. It could be a workflow to be discussed and figured out. And part of that functionality may be in your existing EHR if you have one, but it may not be.
We'll also hold this question as well when we start developing our VEX series on workflow. Yeah.
Okay, that's a great idea.
Yeah. Okay. This is a really good question. So, patient electronic access. How do you meet this if there is no patient portal or PHR?
Right. We had to provide, it's also called timely electronic access. And so any certified EHR has the capability to do this.
Right. That's part of the deal. Yeah.
Right, that's part of the deal. And so some certified EHRs or certified modules around timely online access, just however your EHR has been certified to do it is the first thing you want to explore. Again, a significant number of these involve uploading these records to Microsoft Health Vault or else they have their own PHR. But any complete EHR, certified complete EHR, has passed the functionality requirements for timely online electronic access.
I mean, that just has to be that has to be included in it. That's or you know.
If it's a complete EHR.
Yeah, right. Because
that's right.
That's where the timely comes in.
Yep, that's true. That's very true.
Let's see here. Let me go ahead and get this next question up. Hold on one second. This refers to the menu set items. Provide clinical summaries for every patient and providing timely electronic access. We're back to this question. Both requiring no request from the patient. Can it be the same information that would qualify the EP for both menu set objectives?
Right. And what was the first one? I'm sorry. It was the electronic copy of health information.
Right. Provide clinical summaries for every patient and providing timely electronic access, and both requiring no request from the patient.
Yes, it could. The only thing that is a little bit different is the clinical summaries is certainly encounter-based. So, and focused on a visit. So that has to be put out there. If a patient maybe didn't come in for a visit, but they went and had some lab work done, and those lab results come into a patient's record, then that would also need to be pushed out. Right. So,
okay. Right. That makes sense.
Right, and so one is really a visit summary, and the other one is kind of a up-to-date snapshot of the patient's record. May not be totally visit-based.
Got it. Okie doke.
Good question.
Yeah, that was a good question, and just another attendee wanting clarification. If a complete EHR does or does not have to upload to a PHR portal? I guess it's that word complete. Is complete EHR versus certified EHR?
No, that's a great question. The EHR's the certification program and process is modular, and so it's possible for a technology vendor to go in and just certify a module for e-prescribing, or for timely access, or for electronic copy of health information. However, if a vendor takes their EHR and gets it certified and gets every one of the meaningful use objective criteria, functionality certified, then they're given the title by CMS as a complete EHR. And that designation of complete EHR means that they have certified every module that would be required to demonstrate meaningful use.
Got it. And considering how many you've done, right?
Yeah.
Right.
There are so many EHRs that have gotten a stage 1 certification. Yeah, quite a few.
Yeah,
more every week.
Yeah, exactly. What's the number right now, Tally, for?
Yeah,
I haven't checked the website lately, but
you know, it's got to be 50 or 60 or 70 or 80.
It's a growing
dozens
number.
and dozens. Yeah,
right,
it may well be over 100.
Right.
Sure.
All righty. Well, we are close to the top of the hour, and just to remind everybody, if you're on the phone that, or listening to your speaker still, that we have the final part of this 5-part series concludes tomorrow night, same time, same MU station. Jim, thanks so much again, and we'll see you tomorrow night. Talk to you later.
Thank you.